Hello, everyone, and welcome to all of you. And thank you for joining us for today's Operation Smile Academy webinar on the management of the protruding premaxilla in primary bilateral cleft lip. My name's Dan Bradley. I'm one of the Global Surgery Fellows with Operation Smile. And we're really pleased that over 400 people registered for this webinar today from over 50 countries worldwide, with representation from multiple specialties that make up the multidisciplinary cleft team. So a very warm welcome to all of you. Please do take full advantage of the Q&A function during the webinar and post your questions to the panelists, which we can then answer during the Q&A after the presentations. I'm delighted to start by introducing David Chong, who is our moderator for today's session. David Chong's a cleft surgeon and associate professor of plastic and reconstructive surgery at the Royal Children's Hospital in Melbourne. He's the current president of the Australasian Cleft Lip and Palate Society and a long-standing volunteer with Operation Smile and Mercy Ships. He's done over 30 surgical programs with Op Smile and recently taken on a role overseeing the organization's commitment to education. Thank you, David. Over to you.
Thanks very much, Dan, and welcome to you all. Thank you for joining us around this very interesting topic. I think I specifically am very excited about this topic because I think it's pertinent to lower middle income countries, the management of the protruding premaxilla in the primary bilateral lip cases and children that we look after. I've specifically asked speakers who come from the full cross-section of all organizations, not only Operation Smile. And I particularly wanted to make this an academic webinar open to everybody so that as an academic community, we can come together and have a respectful debate about a very controversial topic. We all want to do the best thing for our patients. We all want to decide, well, otherwise we wouldn't do what we do. So we all feel strongly that what we do is the right way to do something. But I think this webinar will give us an opportunity to hear from three experts about the various ways one can manage the severely protruding premaxilla in the bilateral cleft lip child. And in particular, I've asked my speakers to limit themselves to 20-minute talks. And then we'll have about a 20-minute question and answer time. So we expect this webinar to run for about 90 minutes. I also encourage you to please write questions. We'll answer all the questions at the end of the three speakers. Thanks for that, Dan. That's really interesting and a nice way to introduce Pedro Santiago, who's currently the Director of Oral Health and Director of Craniofacial Orthodontics at Duke University in the United States. He's the lead global advisor for oral health at Operation Smile. He's a founder, professor, and director of the orthodontic graduate program in the Center for Craniofacial Disorders at the University of Puerto Rico between 1996 and 2008. And as many of you know, he's published many scientific articles and book chapters in international orthodontics and lectured in international meetings in over 30 different countries. You've got a wealth of experience here, Pedro. Thank you for sharing with us your thoughts about nasoalveolar molding in the primary bilateral cleft lip patient.
Thank you, David. And thank you, Dan Lawrence, for your hard work and for inviting me to share the podium with our friends, Renato and Fernando. I'm going to speak about NAM and the prominent premaxilla. Managing the protruded premaxilla has been one of the biggest challenges in the history of cleft care. This is not new. When we go back to history, since the 15th century, it has been reported from premaxillary excision to external compression to bonnets and tapes. We have always looked for a way to deal with the protruded premaxilla, especially surgeons. But we go back to the pre-surgical infant orthopedic modern era. It started with McNeil in the 50s, then Georgette at Duke University, Georgette and Latham in the Duke University, UNC Endeavor, then the Millard and Latham appliance, and we have to include lip adhesion as an orthopedic force to retrude the premaxilla. But any of these techniques, when we look at the history of pre-surgical orthopedics, There have the similar goals: to reduce the severity of the skeletal, labial, and nasal cleft deformity and facilitate surgical closure. If we can do that with a pre-surgical orthopedic appliance, then there's less aggressive tissue undermining, less tension at the suture line, and hopefully better aesthetic results. But how was nasoalveolar molding started? How was it born? It was many of us, and this is photos from NYU, where you have a perfectly fine nose. You see the nasal tip protruded, good symmetrical shape and form, but an extruded or protruded premaxilla with a short columella and lip segments way, way far apart. So there's not much the surgeon can do in cases like this. And this is the same case after surgery. So surgeons and orthodontists and providers were very frustrated because then you have to deal with patients with this kind of results when they reach the teenage years. And these were patients that I treated in my residency when I was a resident. Sad faces, flat noses, short columellas, multiple surgeries at the base of the nose and lip to try to replicate a normal columella that didn't really work. It was in the 1984 paper, Matsuo and Hirose from Japan, that they ignite this interest. Matsuo and Hirose, they started correcting auricular deformities. So different groups, Grayson and Cutting in New York, Pedro Dogliotti and Ricardo Benun in Argentina at the same time, and they didn't know each other at that point, started saying, if we can mold ears, we can mold noses. And they started the nasoalveolar molding process. But interestingly enough, the main concern initially was the bilateral. It wasn't the unilateral. This is the first paper written in the literature by Grayson and Cutting in '93. It was a letter to the editor showing them, yes, we can elongate the columella, we can help the surgeon get a better result. So in '98, we published our first paper that was on columellar elongation in bilaterals. And I urge the surgeons to look back and look at this paper. This is the way where nasoalveolar molding and surgery can improve our outcomes in bilateral cases. So this is not new. So we published this in '98, and NAM without a primary rhinoplasty shouldn't exist. So read the paper and see how NAM is just an adjuvant in your tools, in the surgeon's tool. It was so interesting. People were so interested back in the day in '98. They were so interested in '98 that the Maxillofacial Surgeons Foundation and the American Society of Maxillofacial Surgeons named it Paper of the Year, that '98. Again, it was a good paper. It wasn't, again, a Nobel Prize, but it shows the interest that the surgical field and the surgical partners had in finally, maybe we have a way to deal with the protruded premaxilla. In '99, we published the nasoalveolar molding technique. This was the original unilateral appliance. It was a all-hard acrylic molding plate and nasal stent with soft acrylic added to the nasal stent to mold the nose in a well-fitted plate and weekly adjustments. So I joined Dr. Grayson in '95 as a fellow. And when I was there, I had to go through different modifications to make my life a little easier, to be honest with you, and try to make the appliance a little more effective. So when I went back home to Puerto Rico, I made some modifications. What we did is that we included a wire-based retention button and nasal stents to facilitate adjustments and activations, and the use of denture adhesive to increase retention and efficiency. And then we moved from 1 week to a bi-weekly adjustments only on a hard acrylic, just to make the provider's life a little easier. So Barry and I, many years ago, decided that this was going to be the way that we were going to practice and teach. And this is your typical NAM appliance. It's just a molding plate, acrylic molding plate with a retention button and nasal stent to work on your nasal deformity. So what are the goals of nasoalveolar molding on the bilateral cases? We want to retract, well, first center and retract the protruded premaxilla. We want to align the alveolar segments to form a normal maxillary arch, lengthen the deficient columella, and narrow the alar base. So this is your typical case where you have a protruded premaxilla, almost no columella. The way we started, we used the molding plate to retract the premaxilla first, and once the premaxilla is positioned between the posterior alveolar segments, we start molding the nose by the use of the nasal stent and some biomechanics. Unfortunately, we don't have all the time to discuss it. We start elongating columella. The columella tissue, like any other soft tissue or skin tissue, can be elongated at any point. Is it easy? No. Those are the longest 4 millimeters that you're going to do in your life, but it is possible. So by the use of tapes and elastics, we start elongating the columella, and this is our patient at 6 months of age. So we do a gingival periosteoplasty in our patients, and we don't have time to discuss this, but this was my fellowship paper, again, in the 90s, where we found that when we do gingival periosteoplasty, we have a 60% reduction in the need of alveolar bone graft at age 7 to 9. So please look into it and include it in your toolbox. And this is the same case at the same child at age 8 without any revision or any treatment at all. So our goal is to minimize the amount of interventions and revisions through the patient's lifetime. So why we do a gingival periosteoplasty? For many reasons. First, to prevent vertical displacement, a difficult vertical displacement of the premaxilla, and future surgical repositioning, as one of our speakers, Fernando, will discuss. The collapse of the posterior alveolar segments, we want to prevent that collapse and prevent the presence of nasolabial fistula and the associated symptoms. So let's look at a very difficult case. Let's say that this case show up to us with a very lateralized and protruded premaxilla. There's no way to take a proper impression for a NAM appliance. So what I do, I take a small impression of the premaxilla. I create a premaxillary cup with some attachments, and we use surgical tapes and orthodontic elastics to center the premaxilla. So we only deal with the premaxilla in 2 weeks, 1 and 2 weeks. The premaxilla will be centered, and then we are ready to take an impression and then start our retraction. Of course, this case took a lot longer than the others because we had to go through that route. And again, it might not be the most ideal result, but a decent result for a complex case in about 6 months. It's important for you, and this question will come up, I guess, how much time do we have to treat a bilateral case? It could be up to a year if the motor skills, if the baby doesn't take the plate away. In unilaterals, it's a different story. So we go from here to here in about 6 months. You know that when I go to the meetings and people talk about a controversy, and I've been in this field for 30 years and teaching them for 27, and I'm always puzzled how interesting is our field and how a little rumor can create a controversy. So I hope I can help on this a little bit. What is the controversy? When we go back to the molding plates in the 1950, when McNeil prosthodontist started his molding plate, the problem is that he claimed too much. So McNeil's exaggerated claims, he used to say that my appliance can improve speech, improve feeding, optimize dental relationship, and facial aesthetics. And oh my God, so he just created a huge debate among especially his students and residents, and many of them very vocal. If you know orthodontists, we can debate out there. So when you look at the controversy, it's always orthodontists, actually not surgeons, that claim, or they're skeptics about what we do. So what do they claim? What do the skeptics claim? They say, look, NAM doesn't do any, it's no difference if you do NAM or no NAM. Might affect growth. Might is very important, right? And now the new one is increases the burden of care. So let's look back to the early studies. When you look at the Euroclef and the Dutch clef studies, this is what they say. This is important for the people that want to do NAM or they are skeptic of doing NAM. The paper, if you go back to 87, says very clearly that pre-surgical infant orthopedics with molding plate has no positive or negative effect on feeding, speech, facial growth, or occlusion. So this is to prove McNeil wrong. When McNeil said that the appliance did all that stuff, no, they just said, no, it doesn't. But it's important for you to notice that he says no positive or negative effect. So that's why we use the molding plate, because it doesn't have a negative effect on any of this. And because we do not claim any of this feeding, speech, or facial growth, then that's why we use it. Is not offensive. They said that pre-surgical orthopedics, I'm quoting their papers, again, the skeptics, said has no effect on facial growth in height and depth. No effect, positive or negative. So when we talk about maxillary growth inhibition, why people think that an orthopedic appliance causes growth inhibition? Well, the problem is that we have, again, a pretty vocal group led by Sam Berkowitz, and I get it. When they look at the pin appliances, Sam Berkowitz was with Ralph Millard and Ralph Latham in Miami, and he saw what the pin retain appliance could do. So Sam has always said that the Latham appliance can affect growth by disrupting the premaxillary vomer suture. Well, a molding plate is not a Latham appliance. And that's the problem. The problem is that we try to put all these techniques in the same bag. And we need to remember that the palatoplasty is a necessary evil. One of our own, Billy McGee and his group in LA, wrote this paper last year on the likelihood of orthodontic surgery in our patients. Well, the result says that almost 40% of our bilateral cases and 30% of our unilateral cases are going to have orthodontic surgery anyways, with or without molding plates. So when we talk about burden of care, that's very interesting. We should define burden. Are we talking about cost, or are we talking about the appliance cost, or cost over the patient's lifetime due to multiple surgeries? Let's take into consideration socioeconomic costs for some of our countries. Instead of looking just at number of visits as a burden, let's look at the number of surgeries that are needed if you don't do it. Stress to caregivers, well, it has been shown that the learning curve is about 1 to 2 weeks, and actually the parents feel empowerment and decrease anxiety when they are involved in the treatment with their children. And it's very important that we should talk about psychosocial burden on our patients. When I question burden to the family, so 3 or 4 months, 12 to 16 visits of their life for their child's lifetime benefit, any of you that are a parent will do that and much more for your children. It is covered, at least in the US, by most medical insurances, if not all, and it is proven to reduce caregiver stress while increasing empowerment. It reduces cost by reducing the need for revision surgeries in the future. So I call it burden to the child if we don't try it and we have the resources to do it. We don't want this. This is not acceptable anymore if we have a center that can provide NAM and primary surgery. I invite you to look at this paper. We wrote it last year. again, as all this skepticism, I invited some of our residents to help me write a systematic review on the literature out there for NAM, of the evidence. And I think it was well written. They kept me unbiased. I wasn't part of it. I was just looking at, my involvement was mainly to explain what was NAM and what wasn't NAM, for them just to look at the papers. So the reality is that there are over 180 articles in the literature supporting the technique. And I'm going to go to conclusions of that paper. So, you know, there's a strong evidence that supports NAM as an improvement in post-operative nasolabial aesthetics. Please listen to this. There's nothing in the literature that talks about growth inhibition by any orthopedic appliance. Again, it's just a rumor. It hasn't been proven. The evidence suggests that the patients that do NAM and primary surgery have fewer lip and nose revisions and requirement of alveolar bone graft. The NAM long-term impact appears to reduce costs associated with avoidable procedures, and NAM does not appear to increase caregiver psychosocial burden of care and may be associated with improved quality of life. So look at the paper, please, and I think you're going to clarify many concerns. And the most important thing is that forget about the claims from McNeil in the 50s. What are our real claims are the following. We believe that NAM restores normal anatomical relationships. By doing that, we facilitate primary lip, alveolar, and nose surgery. By the surgeon being able to do surgery in a better environment, it should improve nasolabial aesthetics and reduce the number of surgical revisions and surgeries over the patient's lifetime. So is it really a controversy or it's just pure skepticism? So please look into it. But there's something that is critical and very important. And this is my role as a craniofacial orthodontist. The degree of the cleft severity does impact the surgical result, regardless how good the surgeon is. My role as a craniofacial orthodontist is to bring those difficult cases and send to the OR the same mild relationship. So all these are the same patients before and after NAM. The upper row is at presentation. The lower one is the way we send them to the OR. When we do that, there's no doubt that the surgeon gets better at what they do and knock it out of the park every single time. So it's not about a technique. It's not about NAM. It's about an interdisciplinary, well-designed, effective protocol. It's about dentistry and medicine working together, minimizing the number of surgical interventions in the patient lifetime while maximizing outcomes. I fully understand that we work in low-income settings. So for those of you that cannot do NAM, maybe you should try the premaxillary cup, or maybe just to retract the premaxilla, do some type of taping, and you can do it on your own. You don't have to buy expensive tapes out there. But I urge you to look into it, and if you have the ability to offer it in your center, please do, and then go from there to Plan B or Plan C. Thank you for the invitation, and this is an amazing topic to discuss.
Thank you very much, Pedro, for that awesome talk. And it really highlights the effectiveness of NAM. And we look forward to asking you more questions specifically about NAM. And I just encourage everyone to write those questions down, and we will definitely get to as many of those questions specifically about NAM as possible. Fernando Almas, who is joining us from El Salvador, where he's with Austin Smiles, another cleft organization. He's a maxillofacial and reconstructive surgeon from Brazil. He's a surgical director of the St. Jude Hospital in Brazil and faculty of the craniofacial surgery residency program there. Fernando, like myself, volunteers 6 months a year overseas with different foundations and has gone over 100 surgical programs in the past 10 years. He has a wealth of experience that I got exposed to through the WhatsApp forum about his thoughts regarding premaxillary osteotomy. So I've asked him to share his perspective on that topic. Thanks. Over to you, Fernando.
So first, thank you, David, for the opportunity to be here. For me, it's such an honor to be first talking after Dr. Santiago lecture. And I need to say, Dr. Santiago, your work is the base of our premaxillary setback protocol. And like you and Dr. David are such an inspiration for me. And I would say hi to a few friends of mine that are checking the webinar, like Dr. Natalie Ruch. So thank you for the chance. So first, I need to say that we're not advocating for a new technique. It's just a new perspective of like not an old, but a very classic osteotomy on the vomer to try to bring the premaxilla back. So I'm not creating anything, because bilateral cleft lips, especially with projected premaxilla, can add more. Is very more challenging even for a very experienced surgeon. So that's no question about that. So the surgeon can be very experienced, but when he faces a case like this with a wide gap, with a very rotated premaxilla, and with a very small prelabium, so it doesn't matter how good he is, it's a very challenging case. So in our experience, we are dealing with cases around the globe. Our team used to go for like 10 different countries to try to help patients over there. So in our anatomical review, we see that setback has been reported for different surgeons and different teams. But what the literature says about it, what we should do when we see like a projected premaxilla, like we can do NAM, we can do lip adhesion, or you can do premaxillary setback. There is no right answer for that. I like to say that for a cleft surgeon, he needs to be like a superhero, like a Batman. So he needs to have options. So it's not black and white all the time. There's a lot of gray on that decision in what to do or not to do. Because sometimes lip adhesion, that Dr. Renato will talk about it, it's a very nice option to do as well, but will add a more scar tissue, and sometimes will fail. Like we can see a no natural lip, and we can also see a no natural lip shape, and will add more scar. I'm not talking about the facial growth, like Dr. Santiago was mentioning. Like the facial growth is not something that you need to be so concerned about it, because it's easier for it's more predictable to do a LeFor-1 advancement than try to deal with cases like this, or cases when you try to do lip adhesion in one of the sides, and then you keep it like fracturing the maxilla when the lip adhesion fail in one of the sides. So this is something that you need to put on the back of your mind and thinking about it. What's the best thing to do in cases like this? So sometimes also with lip adhesion, the pressure against the lip is so high that the premaxilla can go through the lip, and that I keep seeing cases like this all over the world, like patients who was so the premaxilla was so projected that the muscle was not strong enough to try to bring down this premaxilla also holding place, but get wide open, and the premaxilla went through the noses. So again, I'm not saying like lip adhesion don't have a place for that. I'm just saying like if you don't have a good NAM team, or if you even when you have a like NAM, those cases can fail. And what to do? Like this is a patient from Lebanon, so someone trying to do lip adhesion on him, and the premaxilla fracture inside the nose. You can see on the CT scan. on the left side, that the premaxilla is inside this kid's nose. So in cases like this, also when you get a nice lip adhesion or NAM, whatever, and you cannot bring the premaxilla down on the same height or the same maxillary arch, it's so hard to close the anterior part of the hard palate. Even if you do like a very nice dissection on your palate, it still will be very hard to reach the anterior part of the palate. So dealing with fistulas like this, again, for a very experienced surgeon, is a huge challenge. You can say it is not, but I don't trust. Like it is a huge challenge to try to close fistulas like this. And we'll add, like Dr. Santiago was talking, we'll add more surgeries. So we as surgeons, we need to have a balance. What is best to do, adding more procedures or be more effective or in having the multidisciplinary approach as a single team. So I don't have the courage to talk about NAM, especially Dr. Santiago here. But NAM, in my opinion, is so technical demanding, needs to be a very experienced orthodontist to do it. And this orthodontist need to have a good training because sometimes you have a very nice case or not that challenging case. And with NAM in the no training hands or not well training hands can become harder. So this is a before and after for a patient who went through NAM with someone who didn't get the right training. So now you can see it's way more challenging to try to do anything because the shells of the maxilla are collapsed behind the premaxilla. So what to do in cases like this is adding a is more challenging, and for sure will be a long way to try to improve this child. And sometimes, like NAM, this one of the patients from Ecuador. So NAM with a bad lip repair. So that's why I love what Dr. Santiago was saying. Like, it's not about surgery and it's not about orthodontists. It's not a fight between them. Like we need to work together as a team, not only as a multidisciplinary team, but as an interdisciplinary team. So we need to go like side by side and trying to find out what's the best for each patient. Like every cleft is a single cleft, so there is no equal patient. So in that regard, like we had like amazing NAM, like this patient was very well positioned, and then the lip repair was not that great, was a lot of tension, and the premaxilla fracture inside this kid's nose as well. So like I was talking about, like this not something that I invented. Like, please don't take that way. Was well described before. I had the chance to work with Dr. Cutting in NYU and Dr. Roberto Flores, and they are like visionaries for all of this. Have been first publishing the vomer osteotomy in 1957, like 60 years ago, with Dr. Cronin. So we just did some changing, and we add we add Dr. Santiago gingival periosteoplasty on that, and our vomer osteotomy has a more three-dimensional approach. So this the classic premaxillary osteotomy is not what we believe is the best thing to do because of the blood supply who come from the prelabium and the nose. So this is the classic approach from the osteotomy, from the premaxilla. You can see that the premaxilla, the osteotomy is only on the premaxilla anteriorly to the VPS, the vomer premaxillary suture. So when that happens, you can definitely put your patient in danger, causing like premaxillary necrose, and like a terrible result. Like we had some of other surgeons did this case in Syria, and this was the result after a tryout for a premaxillar setback on the premaxillary condyle. So imagine how to try to fix this case. So again, I'm not advocating that premaxillary setback needs to be done for everyone. It's not for all the cases. Again, the surgeon needs to be like the Batman. You need to have like the utility belt to have options. So this is a good option to do it, because like Dr. Santiago also was mentioned, like pretty much 40% of the cases for bilateral cleft lip and palate patients will go through a LEFOR1 advancement. So it's more predictable to do that than try to fight with anterior fistulas, like fracture premaxilla or premaxillas going through lips. And just a side note, like we understand that the only way to prevent premaxillary retrusion is not having any surgery. So unfortunately, we keep seeing patients like this in undeveloped countries. Unfortunately, this is a patient from Brazil that never had been treated before. So he's the one who never, because he never had treatment, so he still had common, ordinary facial growth. So what our surgical considerations. So those are the anatomical reveal. So the VPS is a junction between the premaxilla and the vomer bone. And this was the classic approach for premaxillary setback on the vomer condyle. So we suggest a new approach only on the vomer, not on the premaxilla. Our thoughts was very similar to Dr. Cronin, like in 1957. We just put some more like technology in our osteotomies. Used to be minimal invasive, and we like to do with minimal invasive and less traumatic osteotomes and surgical saws. We prefer to use piezo saws, and we like to do like minimal incisions, so we're not being that aggressive in that area. We definitely we maintain the septum in place. So this is our surgical markings. So the VPS suture. So we start our premaxillary setback with the double wide conjoint incision, just like any regular bilateral cleft palate repair. So this a video. So it's like standard procedure for palate repairs. So we can visualize the vomer. And then we start our measurements. So one thing that we're doing differently, we're trying to have these 3D incisions or osteotomies, so we can put the premaxilla in place with some rotations as well. So we fully believe that if you bring a better anterior nasal spine in place and you can be able to do gingival periosteoplasty, that will be more beneficial to the patient. So then you see our vomer osteotomy. We use piezo saw, like I mentioned, and there's like a minor, I cannot say no, but there is a minor lesion on the septum. And then we take a piece of the vomer, like it's showing there. You can see the flap raise, the fragment of the vomer bone. And this is the vomer bone on the lower left side. You can see on the back of, after we took out the piece of the bone, you can see some septum sitting down nicely there without any concerns. And then after that, we'll be able to set back the premaxilla. So we decided to do verticals, like angle osteotomies, to increase the bone contact. So after 1 year, when we perform the palates in our patients, the vomer bone is fully healed, so we can re-raise the flaps without any problem. This is like a video that's showing the whole movement that we can have. It's very easy. We're not doing that much pressure to do it. It's pretty much loose. And if you pay attention on the vomer part, you can see like the bones are aligning. So that will give us a better chance for a perfect or most perfect as possible gingival periosteoplasty. And we'll send to our orthodontist team the patient with a better maxillary arch. So that's what we're looking for. Even in patient that lip adhesion fails, we can do the premaxillary setback, put the premaxilla in place, and then do the lip revision or the proper primary lip repair. So this is a before and after from one of our cases. So we can see now on the right side, the after picture, that we have a better maxillary arch. Again, I'm not talking about facial growth yet. I'm just saying that if I deliver this outcome to my orthodontics team, will be easier for them or less challenging. I'm not saying easy, will be less challenging to deal with true like maxilla as a regular patient than having all those like anterior fistulas and difficult to reach the flaps, the palatine flaps and things like that. So it's just a different way to deal with this. Again, I needed to mention Dr. Santiago paper about gingival periosteoplasty and the chance of bone growing in that area. We're so happy to do that in all our patients, and we still need more data because we're doing this kind of procedure for around 10 to 11 years, but all of them are showing very nice like growing, they're growing bone in that area. Probably around 6% of the patient are going to need less bone graft in the future. So like we were talking, it's more predictable to do the case on the right side than on the case on the left side, even for an experienced surgeon. That's our belief. So that's why we decided to use as protocol. If you have a premaxilla projected more than 10 millimeters, we used to set back the premaxilla in place. So this follow-up from one of our oldest patients, older patient, we can see his facial growth by pictures and by CT scans are not being, it's not a big problem because I have amazing orthodontic team and they're taking care of interceptive way to our in our patients. That means like I'm not waiting until the patient get hypoplasia on the middle third face hypoplasia. I'm not waiting for that. Actually, we're like doing interceptive orthodontic treatment. And this is the case after a few years. You can see how much bone we grow in that area with our gingival periosteoplasty. So even if this patient starts having like a middle face hypoplasia, it's more predictable to deal with this than trying to close fistulas and trying to reach flaps and do buccinatal flaps or fan flaps, or like I have some surgeons doing like microsurgeries on those cases. Like, you know, I don't know. I think like less surgeries are and more disciplinary approach is the best way to do, but that's my opinion. This is our studies that we have been publishing on the past years. Again, we still need more data to make sure that our patients are not having a different or a different facial growth than regular bilateral cleft patient. Of course, premaxilla setback has a lot of advantages, but at the same time has a lot of disadvantages as well. So again, by the end of the day, I would like to say that this is not related to what I think. It's just a different way to do this, especially when we don't have a good multidisciplinary team, when we don't have a lot of support, or like me, like as a cleft surgeon, I used to do like 10 missions a year, and they're so hard to have all this support, like in places like Uganda, like Ghana, like Tanzania, like Ethiopia. Like it's so hard to have all this like pre-orthopedics treatment. And I think there is a place for premaxillary setback. This is some of our patients. So to reach outcomes like this in a single surgery, I'm saying like it's not something that everyone needs to do or should do. I'm just saying like in our team, in our protocols, in our approach, we can have like outcomes like this with only one single surgery that we can perform the lip revision, or lip repair, nasal repair, anterior palate repair, and gingival perosteoplasty. So some of the intraoral pictures, and again, as a maxillofacial surgeon, I love to see my patient's mouth. So I'm not talking about only the lips, because the lips can look great, but the patient will have a lot of feeding problems, or like the cleft patient always smiles without showing the teeth. So I want that. I want him to have like a big smile, and to have a big smile, he definitely needs to have like the maxilla in place and a good dental treatment. So this is a before and after that the patient that went through NAM, and again, in a no-experienced surgeon or orthodontist, sorry, and NAM fails, and the premaxilla collapse behind the premaxilla, and we did the premaxillary setback with some of like maxillary expansion at the same time. So after that, we were able to do the gingival perosteoplasty, and we were able to do the primary lip repair without any problems.
Just coming up to 20 minutes, Fernando. So
I'm finishing. Just a couple of more slides. Sorry, David. So let me run from the cases. So that's the case that I want to show. Again, went through NAM. NAM unfortunately fails, and we did the same. Like we expand the maxilla shells and just bring the premaxilla down, put in the right arch, and did the lip repair. In some adult old patients, same things. A more predictable way to do this. This is the patient that I showed before, the premaxilla fracture inside at the nose. So just showing that even in non-cleft palates, we can do the premaxilla setback with the vomer osteotomy. This is the video that when we bring down the premaxilla from the kid's nose, and we're able to add that on the arch again with some good gingival perosteoplasty, and we changed the profile of the patient for his life. So again, just running through the cases. I just want to say thank you again, David and Dr. Santiago and Dr. Renato, for the chance for to be here and to share my experience. You all of you are such an inspiration for me as a younger surgeon. I still have a lot to learn. Just the last case, I promise. I'm sorry, I got excited. So this is a case that we did here in El Salvador, like yesterday, 2 days ago. Someone did the lip repair, and the premaxilla was fractured inside the kid's nose when she was not able to breathe. So we bring the premaxilla in the right position, gingival perosteoplasty in both sides, and she has now a better profile. And she still needs to heal more. It's just like 24 hours after her surgery. I think that's what I did. I was here to talk. So thank you so much again for the opportunity. Sorry, I got a little bit nervous with all those amazing surgeons around, and And thank you again for the opportunity, David, Pedro, Renato. It's such a privilege to walk beside like amazing surgeons like all of you.
Thank you very much, Fernando, for bringing us through that. Technically, I think NAM is technically demanding, but I've always thought that premaxillary osteotomy is one of the scariest and most demanding technical procedures. And I look forward to debating about the various ways that we can do it and the various approaches in the question and answer time. But thank you for your thoughts and sharing with us your technique there, Fernando. I invite again the audience to continue to put questions in so that we can have a nice debate in about 20 minutes. I want to go on and say that he is a great inspiration to me. I love your results that I've seen, Renato, from doing bilateral cleft lip repairs using this lip adhesion technique. Please share with us your talk. Thank you again, my friend.
Yes, I do premaxillar setback. Yes, I do. This is one patient with 12 years, just arrived for me from outdoor center with this kind of premaxillar position. So I decided to do for him a premaxillar setback. We prepare this patient. We're planning to do a new arch and one plate to use after. And then I did a premaxillar setback. We can see here the after and finishing the treatment. It's another patient with a 5 month, just arrived with me this. I did a lip adhesion. We can see him with a 4 years, with a lip adhesion, then 6 years, and then 10 years. With 10 years, I decided to do here the premaxillar setback, put up bone grafting. We can hear 14, if we can see the patient 18 years after. Yes, I performed for him a premaxillar setback. This is the same patient, 18 years after, 20 years after. Yes, I do premaxillar setback, but in a secondary moment, not in primary. Bilateral cleft lip, it's always difficult. And we have many unsatisfactory results as Fernando Almas presents. Yes, I can see this case. Actually, normally, we can see this patient with, could say, not experienced surgeons. So when you see this case, I can remember that I saw many cases these in missions around the world when a surgeon just spend 1 week doing this and we can have this kind of surgeries. But I do not do these kind of results in my private, in my clinic. And the reason of this kind of results, it's tension. For me, it's tension. The patient arrives for the missions and the surgeon try to do a complete surgery, and then we can have results like this that Fernando presents also. When you see incomplete and complete cases, it's important to understand that it's different. We have a tension much more in the right side than the left. And we can have a rotated premaxilla. We can have a small prolabium. We can have an overproject premaxilla. And these patients are different. We need to have a special attention for this patient. Spina, in 96 too, he think about this. He thought about this and he decided to do the treatment thinking two things. Dimension of prolabium and projection of premaxilla. If you have a small prolabium, if you have an overproject premaxilla, I cannot do a definitive surgery with a 3 to 6 months. He thought that we should wait to do the surgery later, and then he could do adhesion. And he said in 96 too that the prolabium forms an integral part of the lip, and therefore should be utilized interiorly, while the premaxilla should not be touched. And he program that we should do a lip addition one side, in the wider one, and then the lip addition the other side, and after 4 years to do a definitive surgery. Nowadays, we're not doing this. We're doing adhesion with between 3 to 6, waiting for 4 years, and then to do a definitive surgery. But when you have a good prolabium, when I have one premaxilla in a position, I can do the definitive surgery, of course. But when I have one not favorable case, I do adhesion. So how can I do adhesion? It's different not to put together. We're not intending to put together. We're going to do more than this. So I do the demarcation of the lip normally, but I do a little bit wider because I want to avoid adhesion, attention this. So I do the mark like I would do a lip repair, and then I undermine all the lip. It's important to release the lip and to bring together. That's I'm trying to present here. I release here the mucosa and the muscle and the sulcus. Then I need to bring the sulcus to the midline. Undermine the premaxilla supraperiosteal, and then in the middle, in the prolabial, I will do a reincision and prepare to have a good stitch to avoid to break this stitch. We can see here, we can see that it's not coming. Why? Because I need to release the nose from the piriform aperture. That I'm going to do right now. We need to release from there. Doing this, I can bring this lip medially easily. So it's not just put it together. You need to undermine, and then I intend to put this without any tension. So we can see here closing the mucosa. And then, oh, sorry. Here. Okay, I just close the mucosa. I don't know what's happened here, but. And then I use one stitch around the nose. I use a 4/0 nylon. Then doing this across the ala, I want to bring this nose and to have not a wider nostrils. So I pass one side for the other one. And then I can bring this nose better here. That's one stitch that we have a good discussion in Edinburgh. David, remember, but I never had problem with these. I passed this stitch without any problem, and then we can see when I give this stitch, you can see what's happening with this nose. Okay. After that, I put the muscle together, and then the skin. So I close the nasal floor, I close the lip, and I put the muscle together. Spina published this addition that I performed in the beginning, one side, after 3 months, another side, and in 4 years, I do definitive surgery. And we can see one patient, a very protruding premaxilla that I know that Fernando would use a premaxilla setback. Maybe the other or can use a NAN, but I did adhesion, and 3 months after, I have this result. And 4 years, this is the patient ready to do the lip repair. And then I can do the lip repair. Another one, look at very protruding premaxilla. This is the patient. 10 years after, maxilla growth is good. Without any problem, you can see here the patient with 2 surgeries. adhesion, very small surgery, and the definitive surgery 4 years. And in the definitive surgery, I have this situation, a very wide prolabium, that I can decide how big I want to have this prolabium. I can decide in this moment that Farkas said with a 4 years, I have almost 90% of the size of the cubital bones of the adults. So I can decide in this moment how big I want. So I resect this tissue, I use this tissue to give the volume of the prolabium, and undermine both sides, the sulcus, bring together, put the muscle together, and I can do this in very easy case. And I reconstruct the deepness of the sulcus, bring this mucosa together, and we can see the nose. Look at the nose after this patient. And I can bring this ala together with this stitch. So this is the patient that we show for 18 years after. But why I do not do a setback in the secondary moment? I think the premaxillar setback normalize the lip without tension. You know, when you do a setback. But if we avoid tension in prolabial sutures, it's better initial static results. But the risk is the perfusion. We have a lot of doubt about maxillary hypoplasia. Premaxillar retusion in premaxilla could be mobile without good healing, bone healing. So we do not find no guidelines, indication, or contraindication of simultaneous bilateral cleft lip repair and premaxillar setback until now. So when we see the follow-up, long follow-up, even for Fernando Almas, we do not see a long follow-up. Another one, my friend Cássio, he presented in 2017, just 1 year post-op of patient, but in this time he was studying the lip impact of the setback. Another paper published in 2018, you can see in days. It's sometimes less than 1 year, more than 3 cases with 4 years follow-up. Another 26 case, we can see no long follow-up. When you see this paper published by Mulliken, 76% of his patients, or 3 to 4, is going to do orthognathic surgery. It's very high. No, Berkowitz came and said about this paper that the history has shown that this mindset of plastic surgeon has always failed. We, orthodontists, have proven that the late surgery to be a later age is more beneficial. So we should think about this. It's another paper published in 2022, and this paper presents all the same things, that we do not have good follow-up. Like a 70% this patient had orthognathic surgery. Premaxillar setback, 70% of patients is going to be. So when you see this paper from Lozzi 2015, that he said that patients with unoperated clefts should have the maxillary growth similar to the patient without clefts. So we need to pay attention in this, because we need to pay attention our lip repair, because we're doing something wrong. If you're doing surgery that we're doing maxillary hypoplasia in 70%. So if I delay the premaxillar setback until 6 years, Murray said that 90% of mid-facial growth is achieved. So if I do not do a huge surgery in this age, like 6 months, we could have a better maxillary growth. Look at this patient, sorry. One patient that I perform adhesion 6 months after. This patient is good, 4 years, definitive surgery, 10 years. Look at his face. Look at his profile. And I'm going to do alveolar bone graft in this moment. So I already talked about this. I saw this kind of situation, and we're doing adhesion in all our patients. I just passed because, but what is the effect of the lip adhesion? Look at this patient. 3 months after, I have the premaxilla in the position without any premaxilla setback, without any taping, without any NAN. It's just adhesion, 3 months. Look at patient with 4 years. Look at position of premaxilla. And then I'm going to do a definitive surgery. Lip adhesion is not a big surgery. Permits a later treatment of lip. It's a physiological treatment. Look at the baby, 10 years. I saw this patient yesterday. I'm going to do alveolar bone grafting. It's a physiological reposition of premaxilla. And you have, during these 4 years waiting for the surgery, enlargement of the volume of prolabium and reposition of the bone. Look at what is easy to do this lip with 6 months or 4 years after lip adhesion. I'm sure that easier to do the lip adhesion, lip surgery 4 years. Others have using this kind of the devices that our presents earlier. But when you see Vo in 1926, interesting because he does a premaxilla setback and lip adhesion together, and then a definitive surgery after. But none can give this position. But it's how Pedro said that we need we have a bird of care. We have a 6 months working on this patient before the surgery. Spina said we can change the patient to complete, to incomplete, and then I can do the surgery later. Look at this patient. After 5 years, we can see adhesion, 5 years surgery, and then we'll follow up. Another patient, 4 years. This patient, 10 years follow-up. Look at the quality of the skin. Look at the quality of the lip and profile. Another patient, 2 years, 4 years, 12 years. Another 12 years. Another patient, 13 years, 12 years. So adhesion permits to have the growth of prolabium and reposition physiological. Look at 12 years after, without any setback. It's another patient, we can see 15 years, 12 years. So it's important to see long follow-up. This is one patient 15 years after the finishing. Look at the occlusion. I'm not going to do orthodontic surgery. Actually, I'm doing exactly in this moment the study about the maxillar growth in bilateral cleft patients, and I never have done one orthodontic surgery in bilateral cleft until now. In my case, I don't have. Of course, we have one Bauru case, 1 or 2, but sometimes we can treat these. Look at, we have one retrusion, small retrusion here, but 15 years after, we can show to Pedro and ask him if he's going to do work on this, but look at the profile for her 15 years after. Another patient, look at how big this premaxilla, and then she's 12 years after. This is another patient, 18 years after. Look at the profile. This patient came to me with 3 years. I decided to do adhesion, definitive surgery, and 18 years. Another one, 18 years of follow-up. Another one, 20 years. This baby came, adhesion, definitive surgery, 15 years. Another 17 years. 17 years. This patient came not to do orthodontic surgery. He did just a rhinoplasty. We can see this patient after the rhinoplasty, and this is his profile. This patient, I did an adhesion a long time ago, but this patient I lost because it's in slides time. So she came back, look at the profile. She didn't have this, the definitive surgery, and then I decided to do the definitive surgery. We can see her 23 years follow-up. So spinal technique using a lip adhesion, it's a definitive surgery at 4 years, and we can have a better definition of filtrum wideness. It's less posterior distortion. It's important. It's a physiological reposition, not aggressive treatment.
Thank you, Renato. Congratulations on your remarkable long-term follow-up. And I look forward to seeing you publish that work, especially around growth and outlining for us the technique of lip adhesion so that people can follow. I was particularly impressed by your noses. What do you think happens to the columella when you do a lip adhesion? All your columellars seem nice and long. You don't seem to be doing anything specific to it, but the proportion, your nasal proportions are particularly impressive. Could you comment around that?
So I do a rhino in the moment of lip adhesion. I undermine the nasal tip. I give the stitch. I bring the ala together. When I'm going to do a definitive surgery, I do again a marginal incision, undermine, put it together. So we can get some enlargement of this columella with the time. So, but I think this patient is going to have the rhinoplasty in the posterior. That I show one boy that I performed like 3 months ago. But I think even using NAN, even using other, we are going to have a rhinoplasty. Besides, mainly in my state that we have majority of patients like a Caucasian, so the nose is big here, is different from Japan or China, or that we nose is not project, but in my area the nose is very project. So the patient comes to do the rhinoplasty, then we need to do rhinoplasty.
Thank you. I'm going to swing back to Nam. Pedro, we were talking before about the optimal time. You know, I was interested in the fact that you emphasized surgery and NAM. Do you think that is related to the age at which you can start NAM on the nose? Did you agree with Gleason's original thoughts that you had to wait till the alveolar arches were aligned before you start working on the nose, or have you changed your thinking about that?
No, so this is the bottom line. It's all about biology, right? So we do not. So the problem with nasal alveolar molding is that it is a concept. So that's why Barry and I said, even when we didn't want to do that, we have to call it Grayson Santiago or GS, so people know that it is not the same flavor as the other 100 flavors out there. We are very active and very creative, and everybody likes to modify modifications. So the problem is that then you lose your perspective. So what NAM does, and that's why we do not start the nasal stent until the segments are closer in unilaterals or bilaterals, because if you put pressure on a distended cartilage, you make it bigger, and the surgeon is not going to be happy with you. The cartilage has the right size. You just have a distorted shape. So why do we need a primary rhinoplasty in unilaterals or bilaterals? It is because what we do on NAM, and that's why the hook doesn't work, is that you have to be sure that you're putting pressure at the domal segment of the lower lateral cartilage. What we're doing is reposition that cartilage, that domal segment, at the tip for the surgeon, but you have to stitch it there because if not, you lose it. So doing NAM and not a primary rhinoplasty, then don't do NAM, because it's not that we're molding the nose, we're repositioning those segments on that crura that you need us to move forward to have a nice nasal tip projection. The same with the bilaterals. So, and if there's a place for them, it's on the bilateral, because it doesn't matter how good you are, you cannot get the 4 millimeters of columella without doing surgery on them.
Yeah, thank you. I think it's a very important point. Can I ask you, there's a question from one of the attendees. In a low resource center, if we only use tapes for the premaxilla, it only moves in one dimension, posteriorly. What PET can be used to derotate it or move it vertically if we don't have a trained dentist or orthodontist team to make the molding plates? Should the surgeons learn the basics of creating one?
Well, we have surgeons that do NAM, because if they don't have, but it's time consuming, and I rather have the surgeon do surgery because that's what they do the best. And unfortunately, that's a very difficult topic, and one for a master course that we have. You can center and retract the premaxilla, but that rotation or that vertical discrepancy, you need an appliance to work into your biomechanics on lowering one side and moving the other up. So the most you can do with tape is just to retract and to upright the prolabium, so the segments are closer for the surgeon to do primary surgery.
Thank you. We're going to keep running for a while because I think this is the most important part of the webinar. So we'll just keep running with some questions, but feel free to leave if you'd like to. This is being recorded, so it will be accessible later. Fernando, you've had a lot of interest in your premaxillary setback, and I must say that it was a great talk. I have a lot of fear around premaxillary setback, obviously, because one, I've never had to perform one, and two, I'm particularly worried about the potential for a disaster, such as the loss of a premaxillary loss of the premaxilla. Can you maybe comment a little bit about, I mean, what is the place of this in a novice surgeon's hands? I mean, if you're a beginning cleft surgeon, or someone even in their first few years of practice, where would you rate the difficulty of this and the blood supply? And perhaps comment a little bit about what are you prepared to do at the same time as your premaxillary setback? Because you sound like you do the GPP at the same time. Are you actually doing the lip repair at the same time? Because it seems to be a lot of work to be doing on the premaxilla at the same time. So, okay, talking about I'm not that experienced surgeon, I would say it is not a difficult technique to perform. Is very straightforward. So if someone knows how to do a palate, will be easy to reach the vomer. So in that regard, it's not that difficult to perform the technique. I think the most difficult part is to understand the three-dimensional rotation and setting back. We can say that we're sliding back the premaxilla. We're not setting everything back. We're not squeezing back the premaxilla. And that's for me, for a younger surgeon, I would say don't go. Wait for lip adhesion is more safe to do it for sure. Even if lip adhesion fails, you can always have the chance to do the setback and the lip repair. So I think you need to be a little bit more experienced to have the full understanding about the three-dimensional approach and to set back or slide back the premaxilla. Regarding the repair, we're doing the whole thing in one single surgery. We're doing the setback, we're doing the gingival perosteoplasty. In all the cases, that's the way we stabilize the premaxilla in place without any wire. We just use sutures from the GPP, and we do I would not say the primary rhinoplasty, but we dissect the domes like any regular bilateral repair, and we didn't have any problems with premaxillar necrosis or anything like that so far.
So because we believe the blood supply is coming to the mucosa on the sides, and we're so far back that everything will be fine.
And a question from Jordan Steinberg, are you relying on the GPP sutures as your only means of fixation for the setback?
Yeah, I would say, yeah, like it's for fixation, and also to follow Dr. Santiago research, and we're trying to recreate some bone over there that's working so far. Is working very well. So, and another thing is good for like setback is that that I don't know what happened with lip adhesion, is that the palatine flaps on your palatal repair or on your palatoplasty, we can reach those. So the anterior tip of the flap is reaching the premaxilla. So our fistula rate on the anterior part is almost zero, because like we're reaching very easily that area.
And one question a few people have asked, there's a few pictures you've shown when you push the premaxillary segment backwards that you've expanded the maxillary arches at the same time. How exactly are you doing that?
So that's a good question. Like there is no, first, we're not doing any osteotomies on the maxilla shelf. That's known. We're using like a device so we can expand and to make room for the premaxilla to slide back. So one thing that concerned me about NAM and to bring the premaxilla back, like lip adhesion, and that we understand that we're tilting the premaxilla. We're not sliding the premaxilla back. I understand as well that the maxillary shelf, they're not the right position for the premaxilla. And the premaxilla is not on the right position, need to be in between, right? So we cannot do a left 4-1 advancement in a 6-month-old kid. So we're bringing down, we're causing probably like some of the misposition on the premaxilla, but it's a better way to add everything there. So when you don't have place to do it, you just put a device like a retractor and you put some pressure on it and the premaxilla will get open. So then we can slide back and do your gingival periosteoplasty. That will be better for maintain the premaxilla in place, because the bone will collapse again. So we hold the premaxilla very tight.
Yeah, it's so you're basically saying that you separate the maxillary arches with some sort of retractor. Okay, yeah. And it seems to actually be mobile. Is that at all ages, or is it at you think it's a specific age that they still?
No, like younger ages. Like I think when you go like Renato was showing, like older patients, you cannot do that. You need like orthodontic device to pre-do that before the surgery. We cannot, because the bone will be too hard, so we cannot expand. Like it's not going to be movable.
Yeah, Renato, I was going to actually ask you. I was going to ask your opinion about whether you do, when you do a premaxillary setback, do you do a similar technique to Fernando? Are you doing the GPP at the same time? Do you have any comment on the premaxillary setback technique that Fernando presented?
Actually, I do not do a primary setback. I just want to do one question for Fernando about this, the same question that we're doing about this expansion of maxilla. We were talking about a patient with a 6 month of age. So the bone is very thin, extremely thin. When you put force to open these, you're not afraid to break this bone from palatal, because to me, it's extremely dangerous to do this expansion, rapid expansion in patient with 6 months. I'd like to know about Pedro about this. What do you think about this, Pedro?
Yeah, so I have to say that it looks a little aggressive, Fernando, but again, it's just a matter of studying it. You know, the main problem is that our alveoli and palatal shelves are paper thin at that age, and by putting excessive pressure, you can be damaging follicles there. But I hate to predict what it's gonna do, because you might be right in your approach. It's just a matter of following it up. So look at the dental follicles, look at dental eruption, I'm not an orthodontist that is looking inside the mouth all the time or waiting 15 years to prevent a surgical event while the child develops a psychosocial problem. So I look at noses and lip, and that's why we created NAM, because I look outside the mouth. But just follow up, as Renato is saying, follow up the follicles and the bone, especially mesial or medial, close to the premaxilla, to see that excessive pressure is just causing any disruption around that. I know it's mobile, we have done it, but sometimes if you have to expand too much, you might be on a gray zone there.
No, I agree, and I fully understand. Like responding to Renato, like we are very concerned about that. So we still have a long way to try to prove anything or to standard for guidelines. It's a long way. So I'm not doing this for 30 years. I'm still doing this for 11 years. So my oldest patient has like 11-year-old. So it's still, I need more time, and the technique has been improving with time. And one thing that's very interesting is, just like you said, like we're taking care of the patients, like, and doing CT scans and taking care of their the dental component. And I don't see any lesions or anything related to that, especially because we're not being that aggressive. Looks like we're being very aggressive, but it's so movable. So we're not pressing or doing a lot of force to get it to fracture. Because as surgeons, we know that to fracture like a kid's face, needs to have like a very aggressive to do that. But we're talking about like smaller tension there, but it still can happen. We didn't happen so far, but we are very concerned about it. But we still need to do more research and to have a better follow-up. I hope we can publish something this year about our 11-year-old patients. And when they finish the facial grow, we're going to have better data. But still, because we're doing those cases in the low-income countries, it's hard to follow up all of those cases, especially with X-rays and CT scans. So every time that I go back, we do some impressions, some cases impressions, and they look very similar to other cases.
My recommendation, Fernando, is that use your fingers to expand it. Don't use any instruments or forceps, right? Because you cannot gauge with your fingers. You do gauge the pressure. Our fine motor skills will let you know, like, maybe this is too much or not. Don't use any retractors or any others because you don't know. So okay. I think you'll be safer by using your fingers. And if those tissues are not allowing you to do that, then you go, maybe I'm putting a little too much pressure.
Okay, thank you. That's a good advice.
And I think as a moderator, it's important for me to also put a little bit of perspective on it, that the procedures that Fernando is describing, I've been impressed by looking at his WhatsApp feed, but it is very high level. And so we're talking about a procedure that can have complications. I have seen a premaxilla turn white with a lot less manipulation than a premaxillary osteotomy, but together with the GPP, and it's a frightening experience. And so I think it's something where it is important for us as surgeons, if you not to just try it, especially at a mission setting. If you're not a senior surgeon, I think it's a lip adhesion is probably a more prudent way of doing things. I really like, Renato, when you first talked to me about lip adhesions, I was like, how can you delay a definitive lip repair till 4 to 5 years of age? I remember thinking, no way, but the results that you show, and in fact, it's so telling that a 23-year-old came back to you having put up with just what was a lip adhesion, but looking very, very good before you did the definitive work. So that was very impressive. We're going to finish up now. Thank you all very much for helping to define a very important topic on the premaxillary osteotomy. I think I'd like to summate by saying that NAM has a wonderful place for low and middle income and high income country with the right passion. And what I think you've shown us, Pedro, is that there is a place of speed and help. And thank you for helping us understand the nose and its effect on the nose and the importance of still doing a primary rhinoplasty despite the NAM that you've achieved. And Fernando, congratulations on your results that you've shown us and a safe way to do a premaxillary setback and the techniques that you use. You know, I would just preface what you showed us for the more junior surgeons that it's a highly demanding technique. Me, myself, as a reasonably experienced cleft surgeon, I still have trepidation around a premaxillary osteotomy. And so we look forward to you presenting your long-term results. We certainly understand that all bilateral cleft up to this point with lip and palate seem to have this high rate of growth protrusion. So we understand your argument about why not close it, accept it, have one piece and move the whole thing forward later. So we look forward to seeing your career develop and hearing your report about your long-term results. And Renato, thank you so much for helping us understand the lip adhesions. I think your results for bilaterals are fantastic. I love what you're teaching us about growth in bilaterals, delaying the technique until later. I certainly agree with you. I think, especially with the Mulliken lip repair that I often do, or Mulliken type lip repair that I often do, that there is a fair bit of pressure that is put on the premaxilla, which may certainly affect growth and may be contributing to this. And so by giving that child a little bit more time, I'm looking forward to hearing also how that affects speech and growth, and congratulations on your results. Thank you all for your time. Thank you all, audience, for joining us on this academic exploration of the management of the protrudent premaxillary and bilateral lips. And I look forward to joining you all again at the next Operation Smile webinar.
Thank you all.
Thank you.
Thank you, everyone. Thank you to our speakers, and thank you very much to David Chong for moderating. And we look forward to joining you next time. Thank you.